I'm glad you came, Jay.
The board, thank you for calling the meeting to order. And I keep turning it on and it comes off there. All right. And this is, of course, we are videoed and streaming and perhaps have a virtual audience. So I'm calling the meeting to order at 10:01. Our first item of business this morning is to approve the minutes from the September 13th meeting. The board should have received these minutes. Dr. Foreman.
Good morning. I have a couple just very quick things. Page 24, I think it's also one ONE could reapply. Small thing.
What's the line number there?
I'm sorry, line 7.
Line 7.
On page 16, I think it's actually me speaking, and the word is, page 25, line 16, the word is implication, not indication, the same as repeated correctly in line 19. There's only one. I don't think much else was oh, I have a question about page 53, line 25. I think this was Dr. Varma speaking. It says there is a gestate skin test. Just a, I couldn't hear that. It was about TB testing.
Which line number are you on?
25, line 53.
Page 25.
Two different types of skin tests.
53 lines. There's a gestate. Oh.
Is it,
I don't know
there
what
is
that
just
word
a
is.
skin test?
Yeah,
It must be just
Just
a
a.
skin test.
Yeah.
Just a.
Just a, not
A
just a.
skin test.
Gotcha.
All right.
And that's it. The other ones were not significant.
Great. And at our last meeting, you noted one substantive difference. We noted an 83% of lead and water tests were positive. That was incorrect. And I don't know if the information was gotten back to you. It was 4%. Was
Yeah,
correct?
I think we said it in the last meeting. Very low.
Okay.
Dr. Bassett, I have a couple of other
Yes.
On page 67, line 2, I think the word should be prospectively. Isn't so much that providers do it
Yes.
prospectively.
Yep.
And on line 8, TBD test, I think it should be TB. Also, I did have one question. Maybe others know this. A few places in the minutes, there's a reference to OATH. Just wondering what that is.
It is an acronym, but I'll have to turn I'll have to turn to our general counsel to.
It's the Office of Administrative Trials and Hearings, so that's the city agency that oversees the administrative courts where any sort of enforcement action or administrative trial that the city conducts, it happens at home.
Is it so when talking about revoking the permits?
Correct.
That would be
Correct.
the place. Okay, thank you.
By chance, it also has a legalistic term, is its acronym.
That's right.
Sorry. One more. Page 68, line 13, it's ID, not RD, in the center of the line.
Good. So those were mainly typographical errors, and they are now noted. And with that, then may I have a motion to approve and someone to second? A motion to adopt the minutes. All in favor, please say yes.
Aye.
The minutes are adopted unanimously. This morning, we have two items for the board's consideration, both of which we will vote on for adoption. And then we will later have a presentation. May I ask if there's a presentation on the first item, the resolution to amend Article 11 and Article 13 of the New York City Health Code. Dr. Varma, if you could identify yourself for the record.
Yes. Great, thank you. Good morning. My name is Dr. Jay Varman. I'm the Deputy Commissioner for Disease Control here at the Health Department. I'll go over our notice of amendment or proposal to amend Articles 11 and 13 regarding disease surveillance. As you may remember, at our last meeting, we proposed a number of different amendments for a number of different infectious diseases. So I'll just briefly summarize what the proposals were, then review the comments that we received, and the changes that we've made to the proposal in response to those comments. The first was to remove hepatitis D and E and the phrase other suspected viral hepatitis from the list of reportable diseases. The second was to add Zika virus, specifically named Zika virus, on the list of named acute arboviral infections that must be reported. The third was to align ourselves basically with New York State and allow non-written consent for the reporting of adult immunizations. The fourth was to add varicella to the list of diseases for which a hospital or other clinical facility is required to isolate a case. The fifth was to augment our required reporting for tuberculosis, specifically as it relates to children under the age of 5. This was to require providers to submit positive radiology reports and to report the initiation of treatment for TB infection. It also was requiring laboratories to report other tests of TB infection, such as blood-based tests, which are now much more commonly used. The sixth was to require laboratories to report indeterminate syphilis test results, and if possible, to retest the specimen and report the results of those tests. And the seventh was to require laboratories to perform bacterial culture when a test is positive using for certain enteric diseases, and then to submit those resulting isolates to our laboratory. So again, the rulemaking process, as you're all aware of, is that the Board of Health approved publication of these proposed amendments on September 13th, 2016. We had a public hearing on October 25th, and also widely disseminated the proposed amendment to laboratories, to healthcare facilities, to physician groups, to professional societies, and we received 4 written comments. 3 of these represented laboratories. 1 represented a national and professional organization for STD controllers. And the comments themselves were related to both the syphilis amendment as well as the amendment requiring culture for certain enteric diseases. So I'll go over what the comments were for these 2 specific areas. For the other amendments that we proposed, there were no public comments, and we proposed a direct adoption of those without any changes. So the first was the requirement about reporting indeterminate syphilis results. The first comment we received is summarized here. We got questions regarding what it means to be indeterminate. The question was whether or not that includes a situation where you have discordant results. That is, you performed 2 tests and they gave you different results. And so we clarified this to mean that an indeterminate result does not include an instance where you have a discordant reporting. Indeterminate is when you perform only 1 test, and that 1 test produces what is recognized on the testing kit as indeterminate. It's neither positive nor negative. So it doesn't include a situation where you've performed 2 separate results and got discordant results. The next set of comments were regarding the amendment to require culture testing and isolate submission for certain enteric diseases. The first comment was about the fact that sometimes a PCR test, what we call a culture-independent test, is positive, but the subsequent attempt to culture the organism is not successful. And so we amended the language to clarify that the isolate only needs to be sent to us if it's actually produced, if it's actually created by the laboratory. The next comment we got was that the testing requirement would result in additional charges for clients and their patients, as the laboratory would have to charge for the work that's performed. So, in our estimation, we know somebody has to bear the cost of this. Somebody bears the cost of performing the culture, whether it's in the laboratory, that's the clinical laboratory, it's the public health laboratory, or society and public health bears the cost for an undetected outbreak or undetected chain of transmission. So our estimation is that we know that this is a cost, but it's a cost that hospitals and patients have traditionally borne, and so we believe that the public health interest outweighs the additional charges that hospitals may perceive they have. We also don't anticipate, again, from the limited experience from other states that have imposed this regulation, there to be a significant issue because most laboratories continue to maintain a culture facility and most of the cost regards the infrastructure, doesn't relate to the individual test being performed. The second comment is about process, about how the laboratory would order a test for culture, because some of them are changing their testing panels to only use the culture independent, like PCR screening assay. So we know this from other tests, and it's very well understood in laboratories. You can order panels of tests. So laboratories can very easily put in place a system that a laboratory that indicates that when a stool test is performed, that it includes both the culture independent test and, if that result is positive, a follow-up culture. So this is something that's already done by laboratories and we think is not challenging for them to implement. There are some technical questions that were asked regarding one specific enteric infection, what's called hemorrhagic E. coli or Shiga toxin producing E. coli. There are many different types and strains, and so we got a comment about how it's not possible for laboratories to culture what we call non-0157H7 Shiga toxin producing E. coli. So we've clarified, this has already actually been clarified in the text, so just reminding the commenters that in fact we did already address this issue. The second related to this, also related to what we call Shiga toxin producing E. coli, it was noted that submission options should include submitting only stool because not all laboratories use a broth method to do culture. So we amended this to basically add the words if available, so that if the broth only needs to be submitted if that's the culture medium in which it was performed. There was one other additional change that we made during the September board meeting where I presented. It was suggested that we add a time frame related to culture-independent diagnostic testing. So we have subsequently done that. We have added language that culture should be initiated or the specimen forwarded to a laboratory that can perform culture within 72 hours of obtaining what we call the culture-independent diagnostic test or CIDT test result. And so that's the end of our presentation.
Now open for discussion. Thank you, Dr. Varma. Dr. Foreman.
Thank you, it was great. I had two quick questions. I think I may have just misheard you, but for positive TB tests in kids 5 and under, you're asking for all X-ray reports, not just positive X-ray reports. The way you said it, but the way it's written says it sounds like all radiologic.
Yes, exactly. Yeah. So we want to verify that a child who had TB infection gets an X-ray performed because that's the appropriate next diagnostic step.
Great. And my second question actually is about the sequential use of non-culture and then culture tests for enteric organisms. And I'm wondering if it introduces any sort of a delay that reduces the yield of your culture testing. When you start saying 72 hours, I don't know enough about it, but does that reduce the chances where as opposed to simultaneous testing?
Yeah, it's possible. I mean, the longer you store any primary specimen, the lower the potential yield is. It's generally accepted that, at least for stool specimens, that they can be held for a few days under the appropriate refrigeration conditions and still be viable. There's still a lot of scientific there's still a lot of understanding that needs to happen about whether or not a result that sometimes is positive on the PCR test but negative on the culture, whether that represents a false positive result, whether it represents an organism that was detected but actually not viable, in other words, something that was unlikely to cause illness, and really what is the gold standard. There's still some debate about that, but our sense is that if there's a sequential performance of the test and it's done within a narrow time frame, that the sensitivity probably will not be affected greatly.
And does the language make clear that that's on the initial specimen? Because one problem that we often have with cultures is that some non-culture test is done and patients started on antibiotics and then
yeah, it's a good. I don't know. I have to look at the language specifically, so we can look at that immediately afterwards to make sure that that's clarified.
Hi, good morning. Thank you, Dr. Varma. Just had a process question. Do those who submitted written comments receive any response, or do they get a copy of the statement of basis and purpose, or what is the process?
Yeah, we don't normally respond directly to groups. I guess there's no reason why we couldn't, in fact. Normally what happens is once we now, assuming the board approves this, what we then do is we usually go back to those groups that we previously solicited comments for and notify them that in fact this was now made aware, that this has now been enacted into law.
And does it include your explanation of how their concerns were addressed?
Again, not normally. I mean, this is something we could do if the board feels that's important, and we do it occasionally with larger groups that we have a sort of long-standing relationship with. So.
I would note that this is a public process, so this conversation is on the record and available to all who are interested. Of course. Yes, it's being streamed, it's on the web, etc. And the rule will similarly be published if approved.
Noted, thank you.
All right. All right, if there are no further questions for Dr. Varma, may I have a motion to adopt this amendment? And a second, all in favor, please say yes.
Aye.
Do I need to note that Dr. Richardson came about 15 minutes ago? Okay, all right. All right, so the motion is approved. We now have a resolution to repeal Article 153 in its entirety. The article refers to littering and disposal of refuse, and it was presented to us by our general counsel, Mr. Merrill.
So there were no comments submitted in response to this proposal. If you remember, this is an old article of the health code that deals with littering and stuff on the streets. We repealed a couple sections in a prior meeting, and now we're proposing to repeal the entire article as archaic and no longer needed. And it really covers things that other agencies enforce, so it's sort of redundant. So, are there any questions?
Any questions from the board?
Just a question about your process of reviewing articles like this, initially wanting to repeal sections of it and now looking to do the entire thing. Is that just a question of having more time to kind of review and make sure that those other...
There was an issue we had to address, which was the city law department. The city has to file certain permits with the federal DEP regarding water discharge on the streets, and in that permit they had included a section, they had to have a plan, and that plan had cited a section, so we couldn't go forward with the repeal of the entire article until we were had assurances from the law department that they were comfortable that the permit status was okay. That's what the plan.
Thank you.
But we're actually going through, and we'll probably be coming back to you with some other old parts of that whole code to look at as well over the next year.
Is that a process that's sort of an ongoing review by the department, looking at various articles?
It's a living document that we look at, but we also, there was a rule revision project that the administration undertook as well, and they highlighted some sections that we should look at. We agreed that we'll probably to clean those up.
Thank you.
Any other questions or comments? If not, may I have a motion from the board? Thank you. All in favor, please say yes. And the motion carries unanimously. Thank you very much. So we will now turn to a presentation from, I believe, Dr. Daskalakis, who is the Assistant Commissioner for the Bureau of HIV Prevention. You could, despite my introduction, if you could identify yourself for the record.
Good morning. Good morning. I'm Dimitri Daskalakis, the Assistant Commissioner for the Bureau of HIV/AIDS Prevention and Control. Thank you for having me here today to present a bit on the work in New York City, focusing on ending the epidemic of HIV/AIDS in our jurisdiction. I start by showing the story of the HIV epidemic in New York City through our surveillance. These are the lives of people demonstrated in a graph. There are a couple of very notable findings on this, which is that our charge to end the epidemic is to bend the curve. And very often, when we started this conversation going to other jurisdictions, people looked at us as if that were impossible. and then we show our slide where we can demonstrate that we have, at least on this slide, demonstrated at least 3 convincing bends of curves in the past. So the pink line represents new AIDS diagnoses. The sort of teal line represents HIV-related deaths. Something changed in the mid-90s. It's a combination of 2 things: antiretroviral therapy that resulted in viral load suppression and people not progressing, nor getting HIV, which we'll talk about in a moment, and then also harm reduction, specifically among injection drug users, with syringe exchange becoming available. So those 2 things resulted in decreases in AIDS diagnoses as well as declines in HIV-related deaths. The 2 other curves that we can detect that have met are new HIV diagnoses. So you'll see that the white line emerges here because that's when we first got reports of all new HIV diagnoses, not just people diagnosed with AIDS. And though I can't tell you where the curve bent at the beginning, you can see that it is a convincing downward trend, with 2015 data not represented here, reaching an all-time low of under 2,500 new diagnoses in New York City. Included in that are 0 transmissions of maternal to child variety. So no transmissions to babies, no babies born in New York City with HIV in 2015. The 4th curve, which is very important and most people don't perceive as a curve, is this curve, which is the curve of people living with HIV successfully. So that we have demonstrated that by preventing disease progression, using viral load suppression, 2 things happen: people live and thrive, and the second side effect of that is that they don't transmit HIV. So when you see the downward slope in that white line, it is driven by the fact that viral load suppression confers high levels of resistance to HIV transmission, which we'll be talking about later. So I present this again to demonstrate that when that sort of universe of impossibility, that conversation of impossibility emerges, we show that New York City has already done it 4 times. So it seems not strange to think that we'll be able to do it once again, driving new diagnoses below the epidemic level. And so, though I show you the statistics and the surveillance, this all doesn't begin with statistics and surveillance. It begins with science, but it actually gets mobilized by community activists. So in this picture here, you'll see Charles King from Housing Works and Mark Harrington getting arrested at the White House. While they were in jail, they decided they were going to come back to New York and end the epidemic of HIV. And that then generated some very good conversations in state and city government that ultimately resulted in an announcement, June 2014, by the governor, that we would work to end the epidemic using HIV testing, HIV treatment, and pre-exposure prophylaxis to prevent new infections in people who are potentially at risk. Ultimately, this initial plan developed into a task force. That task force resulted in a blueprint, which is this yellow document here, the blueprint to end the HIV/AIDS epidemic in New York State and New York City. Ultimately, New York City then came to the table as the first jurisdiction that actually has a plan to end the epidemic that's backed it up with funding. So San Francisco has a Getting to Zero plan, Washington has an End AIDS plan, and there's $0 associated with those plans that are new. So New York City and New York State have actually put money behind the plan to actually bend the curve for the 5th time to end the epidemic. And so these are our projections of where we are so far and where we will go in the future, with the 2020 mark being 600 new infections in New York City or fewer by that year, to reach the point where people entering the system, the number of people entering the system is less than the people who are exiting the system, either by, hopefully not AIDS-related deaths, but by death or by leaving the jurisdiction. So the bottom line is that this part, up to 2015, demonstrates real data. And I'm showing you 2 bars. The dark bar is new diagnoses, so that includes both new infections in people who have established infections and new infections or incident infections. So you can see that in 2015 we had about 1,493. So you can see that looking at our projected slope of decline, we are on target for reaching our 2020 goal. It's a pretty exciting sort of demonstration. Interestingly, the CDC has actually decided to eliminate incidence testing. So we're going to have to do a lot of our work based on modeling unless there is a new strategy that they present to do incidents. So we do have a pretty consistent trend between new diagnoses and new incidents. So we're able to sort of to say that about 1,350 new diagnoses will probably represent 600 if we're not able to actually do that lab-based testing. So the New York City Ending the Epidemic strategy capitalizes on the blueprint and actually enacts it with implementation. So there are about 4 categories of work that we're doing: increasing access to HIV prevention services, promoting innovative and optimal treatment for HIV, enhancing methods for tracing HIV transmission, and then ultimately, a very important strategy is improving the sexual health equity for all New Yorkers. We're doing this in two mechanisms. The first, external support of our partners. So community-based organizations and clinics will be funded and have been funded to do certain aspects of this work. And then internally to repair and enhance the STD clinic to make them really the most cutting-edge delivery system for HIV prevention and initiation of antiretroviral therapy in the country, if not the world. In terms of increasing access to HIV prevention services, it begins with an expanded toolkit that we have. So I'll remind you that there is mounting evidence that people who have viral load suppression do not transmit HIV. In fact, Carl Diefenbach on AIDS.gov has a wonderful video where he actually says that there is zero risk of transmission for people who are consistently virally suppressed. And so durable suppression is the message. The bottom line is that we are believers in this, and I can go back to our first slide to demonstrate the decreases in HIV diagnoses that are driven almost entirely by viral suppression. We continue to cover the city with latex, 37 million condoms distributed throughout the city, and that will never stop because we have about 50 to 60% of people who use them consistently. But for the people that do not use them consistently, we have new interventions, pre- and post-exposure prophylaxis, to use antiretroviral medicines using an evidence-based strategy to prevent HIV acquisition. And then finally, it all starts with HIV testing. So a lot of the work, that toolkit really relies on the fact that we have very high levels of testing in New York City with our current estimate that less than 6% of people are unaware of their diagnosis of HIV compared to 14% in 2010. So we made a lot of progress. So in terms of access to pre- and post-exposure prophylaxis, this is some of the work that we're doing with our external partners. We are opening several post-exposure prophylaxis centers of excellence through New York City. We've heard from New Yorkers that they don't like going to the emergency department for this, and so what we've done is launch them ultimately it will be 5 boroughs, to an urgent care model where people walk in, and one of the deliverables in the contract is that they're started on PEP within, I believe it's 30 minutes of landing, to really remove the emergency aspect of it. Once they land, they get quickly triaged and they start medication. Additionally, we are taking an Elton John AIDS Foundation funded call center, which actually I started when I was at Bellevue, and it has now been funded through New York City to be a citywide 24-hour PEP call center. Patients can call, discuss their exposure with a clinician, and that clinician will provide a starter pack of medications to a pharmacy, pre-HIV testing, and then will be referred to a center of excellence next business day to get their HIV testing. So it will make it feel a little bit more like Plan B in terms of emergency contraception, which I think is appropriate. We've also funded some Ryan White Part A care coordination sites to do something that we think is a very good idea, which is to allow them to see HIV negative people as well. So Ryan White providers are not allowed to see HIV negative patients for the most part, but with New York City funding, they'll be able to see people with new STI diagnoses, people who are candidates for pre- or post-exposure prophylaxis, and people who need hepatitis C navigation as well, added to the contracts through New York City funds. We're also going to open 3 demonstration centers for PrEP for adolescents. They will be following exact regulations for consent for pre-exposure prophylaxis for adolescents, but it appears in the governor's most recent press release that there is a motion toward trying to allow adolescents to access both pre-exposure prophylaxis and treatment without parental consent. That's not yet realized yet, but it is in the most recent World AIDS Day press release. And additionally, we have launched a citywide PrEP network that funds HIV testing venues, community-based organizations, as well as clinics to include PrEP navigation or actual PrEP prescription and adherence support in their settings, and requires them to be organized through memoranda of understanding, so they must work together to create a network throughout the city, and it spans 5 boroughs, so which is great news. Beyond actually doing it, we want to make sure people know how to get it. And so we have just introduced on World AIDS Day our new campaign called Stay Sure. Last campaign was called Play Sure, talking about teaching people about these interventions. And so now Stay Sure is about saying where to get it. And one of my favorite features of Stay Sure is that we're actually promoting emergency PEP for the first time in the jurisdiction and saying you can get it in our STD clinics. So it's no longer an abstract, it is the real, you can land there and this is how you do it. So in terms of promoting optimal treatment for HIV, we have a couple of strategies. One is we are supporting several organizations in New York City to scale up a program that was founded by Housing Works called the Undetectables. So here I have the continuum of care for New York City as of 2014. It demonstrates 72% of all New Yorkers with HIV have achieved viral suppression, which is fantastic. But to end the epidemic, we have to go from fantastic to super excellent, even beyond fantastic, whatever that adjective would be. So Undetectables is a strategy that uses everything that we know how to do, including case management, care coordination, pill boxes, text reminders, all of that kind of work. But it also includes financial incentives for people who need them to help them with viral suppression. So people could potentially get $100 per quarter if they're virally suppressed. There is some data from HBTN studies that this is something feasible and it has efficacy. And so we're going to see what happens when we enact it in a real world model. We are also using really cutting-edge molecular epidemiology to enhance the way that we're tracing our epidemic and then actually improving how we're working on field services. We're doing that by both upscaling the capacity of the public health lab as well as adding field services staff. So the public health lab, as of about a couple of months ago, started doing HIV resistance testing. So providers, specifically in the STD clinic, which is round 1, are able to send resistance tests among newly diagnosed individuals, and they will run that test and report it to the providers who will take care of the patient ultimately. The side effect of this is that we have the full sequence of the virus in real time. It doesn't have to go through the pathway of the test going to the state and then coming back to us in surveillance. We have it within a week and a half to 2 weeks, which then means that we can put it into our database and match it to the 137,000 other resistance tests and sequences that we have to identify clusters. And within those clusters, if we find people who are potentially virally unsuppressed, we will prioritize them for our field services to interact. Very recently, we have also overlapped resistance to that as well, given a recent case of breakthrough HIV infection in a PrEP user. So we are prioritizing the resistance mutations that would make it possible to transmit for field service investigation as well. So it's pretty exciting. We'll be able to both map transmission and then also make it something that we do for our field services strategy. A great example is we have clusters where we have all women in the cluster, and it's a growing cluster. Somewhere in there is a male who's transmitting HIV. And so this will allow us, with field services, to have more interviews and hopefully find someone who may not know their HIV status, test them and bring them into care. So it's an exciting innovation, and again, something that Dr. Varma really has been significant in spearheading. So it's sort of, we are the first jurisdiction in the States to do this. Vancouver has a mature program and it works. Finally, probably the most important thing is our work at improving sexual health equity for all New Yorkers. So there's some things that we're doing that are programmatic, that are sort of outward facing, and then things that we've done internally to improve our own infrastructure. In terms of work that we're doing outside, several trainings have been launched focusing on sexual and gender-related health issues. We are currently working on an LGBTQ healthcare Bill of Rights. Its name may change, but it is a document document that will help LGBTQ people to both know what's appropriate for their care and also where to find it. So it's going to be a web-based document that will say, all right, gender appropriate care, click, and then it will list the resources. So it's not just a piece of paper on the wall. We have an LGBTQ Health Equity Coalition that now includes 70 organizations. We have figured out a way to fund grassroots transgender focused and specifically run organizations in New York City, and also provide them a mentor organization so they can grow and prosper. The 4 organizations in some cases had their funding increased by 100-fold by this, and they're all very excited and have actually started to have wages rather than volunteering their time, which is a great switch. And then also we're launching some interesting work in the injection drug user space, given that we're worried that we do not want to be another Indiana. We don't want to have CHIV outbreak, so we're working to teach newer injection drug users about harm reduction. And then also, because signals that we've seen in our surveillance about crystal meth use are launching the United States' first municipally funded crystal methamphetamine program, similar to one in Australia. And so we actually did a pretty significant needs assessment. I'm going to focus on meth for one moment because it's something that we don't talk about very frequently. So we did a needs assessment throughout New York City in terms of agencies that provided crystal methamphetamine services. You can see the list, pretty extensive. But the approaches were fairly limited in how they dealt with meth users. We also found there was a pretty significant interest in crystal meth treatment among communities and providers, and there was a clear need that a resource guide was needed. So when you look, in terms of places that did work in this space, there are some that actually had specific training, 50-50. Most didn't. In terms of specific programming for MSM, most groups did, some groups didn't. 63% were abstinence-based, so this is the problem. And so our meth program that's launching is not abstinence-based. In fact, it has a community advisory section and a medical advisory section to identify both biomedical and social interventions that will support the meth user. If their goal is abstinence, we'll support them. If their goal is harm reduction, we'll support them. And then the other issue is that there are some programs, the ones that are actually well-known, that have a wait list. And we are launching 2. So one will be Housing Works with GMHC, and the other one will be Callan Lord and the LGBT Center. So they're positioned very well to do this. The actual request for funding leverages both New York City funds and Ryan White funds. So we're blending the two into these 2 programs, so people living with HIV are able to access certain services and twin services we provided for HIV negative people, but on New York City's dime, to make sure that we're able to provide equivalent work. The organizations are a fusion of a CBO and a medical provider, so there's prescribing power as well as service power. And one of the features that I think is really exciting is it will include a drop-in center. It will eventually be off hours. The support meth users should need a place to just be, which is something we've heard from the community. Then finally to the STD clinics. So this is where the biggest news is. The STD clinics are central in our ending the epidemic strategy. It is for the Department of Health the front line for people who are at the highest risk for HIV acquisition. From the perspective of HIV, 10% of new HIV diagnoses are made there. 20% of acute HIV diagnoses are made there, the ones that are the highest from the perspective of infection perspective. We know that it's a safety net for some people living with HIV who aren't connected to care. And we also know that there are models out there in the world, specifically in San Francisco, that people who you start on meds immediately at the point of diagnosis do better, get virally suppressed faster, and have a astronomically high level of retention to care, over 90%. So we also know that our STD clinics are pretty good at doing this already, in fact, excellent. And so again, driving from excellent to even more fantastic. But the negative space is also very important in the STD clinic. We know that 65% of the patients who have been surveyed there want to start pre-exposure prophylaxis at the STD clinic. We also know that they see the patients who are at very high risk for future HIV seroconversion from the perspective of syphilis as well as rectal STIs. So they see potentially thousands of PrEP candidates. Also, their diversity is multi-domain, both from the perspective of race, gender, and sexual activity. It is also our opportunity to transform the STD clinic into a gateway for primary care in general, a portal to the other services that are so rich in New York City. So this is, these are the cold stats of why it matters. 1 in 42 MSM who are attending HIV STD clinics will be diagnosed with HIV within a year of their visit. 1 in 20 who are diagnosed with primary or secondary syphilis in New York City as a whole were diagnosed with HIV within a year. And 1 in 15 diagnosed with anorectal chlamydia or gonorrhea were diagnosed with HIV within a year. So we're in the right place to launch interventions. And to do that, we're going to make the STD clinics, this is well in the process of happening, and many of them are already there, I think, make them not just the place that you go when you have a sexual complaint, but where you go when you want sexual health. And so we're making them destination clinics for all New Yorkers. We're going to increase access to welcoming services. The facilities are getting renovated, both in mission and in space. Hours are expanded. HIV services, I will thrill you in a moment with some of the work that we're doing. STI testing capacity is expanding. Prevention services have expanded, and it's not just about a biomedical intervention, but also navigation to your next step. And we're updating patient educational materials and increasing the level of community engagement with the clinics. So in terms of HIV prevention at the STD clinic, we're going to be launching really increased testing, and then also testing using our 4th generation rapid test, and continue to do our screening for acute infection that we do through pooled nucleic acid testing. But it doesn't end there. It used to be that the STD clinic would provide 3 days worth of PEP, and then refer people to other places to get PEP. And as someone who has prescribed a lot of PEP, there's a lot of systems issues that happen with that handoff. And it also creates a duality between insured and uninsured patients, because they will only get little packages of medicine rather than the full course. That is officially done in New York. All of our clinics are now giving 28 days of post-exposure prophylaxis if people choose. Pre-exposure prophylaxis navigation has launched at all of our STD clinics. And in December, which is now, the first clinic will go online actually prescribing pre-exposure prophylaxis based on rapid HIV testing, so point of care initiation of PrEP. And all of them end at the idea of navigating someone to a provider to look after the rest of their general and sexual health going forth, with the STD clinic there as a background and as a safety net if needed in the future. But it doesn't just end with people who are at risk for HIV. For HIV-infected patients, Jumpstart is our immediate antiretroviral treatment program that launched a week and a half ago. We have already put 3 people on HIV medicines, a historic moment in New York City, where the STD clinic is starting newly diagnosed people with medicines at the point of diagnosis, and then navigating them to places that have high-level viral suppression for their ongoing care. It's very exciting. So we've joined the ranks of South Africa, Malawi, and San Francisco. And we actually consulted with San Francisco in terms of how they've done it to make sure that we look similar, although our context is very different and much larger. This will be upscaled over time. In terms of the work to get this done, Dr. Varma and the team actually activated us like an emergency, like we're at an outbreak. So we had a cross-divisional DOH-MH team that met regularly as if though HIV were new again, to sort of deal with it. And 125 of 136 new full-time staff entered the Department of Health in a very short amount of time, 1 year. We have selected all of our external organizations. Our STD clinics are currently getting reborn with some physical changes, as well as I said, changes to their mission. And our clinic operating schedules have been extended by approximately 10 hours per week. Lots of expanded services. I won't read them all for you, but you'll note that the word HIV does not appear on this slide at all, because it's about making the clinics somewhere that people want to come by providing services they would like to get. And so we're actually including a lot of work within ending the epidemic that is only vaguely related to HIV, but anything that supports sexual health is HIV prevention. So that's the message. And this is just a timeline of the work. So you'll see, as I said, all clinics are doing 28 days of PrEP revision. All clinics are doing PrEP navigation. PrEP initiation is about to launch. And one clinic has started immediate antiretroviral starts or jumpstart. So this is what it will look like in the near future. But we also have changed the concept of what we're doing in the city. We were the first jurisdiction to sign on to a consensus statement that says that people who are virally suppressed pose a negligible risk of HIV transmission to the community. Subsequently, a couple of other jurisdictions are coming, and the National Association for State and Territorial AIDS Directors signed up after us. So we actually were the reason that they decided to sign on. Additionally, Carl Diefenbach, like I said, then went on AIDS.gov and said there are no transmissions in any study of people who are consistently virally suppressed. And so we have translated that to our ongoing mission to address stigma, which is really the center of ending the epidemic, with the concept that to do this, we need to get New York City to status neutral. And I'm going to show you a short video that we played at World AIDS Day, and then show you our status neutral cycle, which we debuted both there and then nationally to now international acclaim. And it didn't work. But it will. Hold on, here we go. Eventually, we're going to voice over this one. This is our status neutral prevention and treatment cycle, and ultimately the message is that the virally suppressed person and the person who is protecting themselves using pre-exposure prophylaxis but at risk for exposure are in effect the same person. So this was released both at World AIDS Day and then subsequently at the National PrEP Conference in San Francisco, and to date has been retweeted 30 times internationally, including HIVMA, the HIV Medical Association, and we have requests for how to adapt it for other jurisdictions, and it's 4 days old. Thank you very much.
Thank you. Well, questions, comments from the board? We really wanted to take a moment to, you hear often about all the outbreaks and the things that are in the headlines. We wanted you to see that the core of our work continues. So, comments?
Blown away. And so impressed. It makes me so proud to live in New York City. I did want to ask you about the funding, because there's an awful lot going on here. And I'm wondering where it's all coming from.
So it's a combination. So I often equate what we do now already as a fleet of battleships. We have our Ryan White battleships, our HRSA battleships, our CDC battleships, and we had some city battleships. But now we have a very shiny new battleship that is pretty much entirely funded by the city, but then draws and leverages other pieces. So like the Crystal Meth program is an example. So we're drawing in some Ryan White funding into a program and then filling the gaps that Ryan White doesn't work with and CDC doesn't work with city funding. Similarly, this idea of status neutral navigation, same idea. So we're using some city funds to enhance our federal funding. So it ends up being a significant support from City Hall, about $23 million that were committed, and then City Council also committed significant funding to be able to support the prep networks, et cetera. And so, we, I think, have cobbled together a plan that shows you how humans will flow through the system to get what they need. And I think the bottom line is that the lesson that we hope the federal government sees from this is that that siloing things based on HIV status is actually wasteful. And if you don't do that, and instead look at what people need who are in the sort of HIV risk or living with HIV space, you'll be able to create a better delivery system.
Yes.
Dr. Gatto.
I just want to thank you for that amazing presentation. When thinking about how much loss of life, how much suffering has occurred secondary to HIV and AIDS in New York City, and to be thinking about a place where we're engaging in a program called End the Epidemic is just mind-blowing. And the program that you all put together at Department of Health is truly remarkable. And the fact that we are devoting tens of millions of dollars to this in a way that other cities are not yet, I think once again places New York City at a position of being a vanguard in improving the health of citizens. So I just want to congratulate your department, Dr. Varma, and the Department of Health for the work on this. I just had a quick question about the PEP centers. Are those going to be open on weekends as well? And for people who come in, will they also be shuttled towards primary care services?
Yeah, so great, both great questions. The PEP centers will not be open on weekends for the most part, but that's what our 24-hour hotline will address. That is 24 hours, after hours, et cetera. And some of our STD clinics are actually open on the weekend. They have Saturday hours, and we're going to be promoting the PEP availability at those clinics as well. So the subway ads coming up for emergency PEP any day now actually say, come to the STD clinic if you want to get post-exposure prophylaxis, or dial 311. Eventually, this 24-hour number will be at 311. So if someone asks for PEP, they'll be connected to that number directly. And the only comment I want to add is that we need to sort of do more work in ending the epidemic that is outside of our normal HIV STD universe, because though HIV-related deaths are decreasing, they actually have decreased below the level of non-AIDS-related deaths, but smoking and hepatitis C are the final frontier from the perspective of improving outcomes for people living with HIV, because they're dying of tobacco and they're dying of liver disease. So that's the next horizon.
Thank you. I didn't ask him to say that, so. Thanks. Ms. Gill.
Wonderful and exciting presentation. Congratulations for the department. In terms of reaching out to certain communities, like the Hispanic community, is this video, for example, in Spanish, community engagement? I'm thinking of CBOs other than the ones that are literally working in this space. So can you comment a little bit about what we do with other groups?
So we will be translating this into Spanish. We've released it in English because we wanted to get it out on World AIDS Day, but the plan is to do an exact replicate of this in Spanish. In terms of our work with Spanish-speaking folk as well as just Latinos in general, a lot of what we've been doing is putting infrastructure closer to where they live. Sort of really like the rest of the department, focusing on neighborhoods. So I don't have this slide with me, but when you look at the STD clinics, one of the remarkable analyses that the Bureau of STD has done is looking to see who comes and who gets, for instance, primary and secondary syphilis diagnosed there. So they have this beautiful map where they made non-STD centers red and our STD centers green. And when you look, for instance, at all men who have sex with men with primary and secondary syphilis, the city lights up red and green. Then if you exclude white men who have sex with men, our clinics shine like beacons, and the red clinics go away. And so by building the infrastructure where people are seeking care, we think that we're going to be offering them a service that they won't get where they are currently. The other thing that we do that's really important is whenever we launch a campaign, we actually do two Spanish language focus groups, trans women and MSM. So we make sure that we get some feedback. We actually have had a cis woman Spanish speaking one for this set as well. So we try really hard to be really connected and also put services where people go.
I should also point out that Dr. Daskalakis has convened groups whose main focus hasn't been HIV/AIDS to begin thinking about HIV/AIDS as one of their issues as part of the effort to address the fact that the majority of men who are living with HIV and the vast majority of women are Black and Latino. So that's been a real change for us, not just going to the groups that have made this their core, but inviting in others and saying you need to think about this.
And we're actually also being precocious in ways to identify women who need PrEP. This is one of the really hard things in pre-exposure prophylaxis. MSM, frankly, are pretty straightforward in terms of who needs to be on PrEP. And so the Bureau of STD and the Bureau of HIV are working very closely together to look at biological markers of potential future seroconversions, such as syphilis and also gonorrhea, as potential ways to identify women who are at risk. So I think that we're precocious compared to other parts of the country in terms of really defining women who need PrEP.
Dr. Richardson, did you?
Thank you.
Yeah, thank you. I'd like to echo the comments of the other board members on really the very impressive work you've done. It's so smart, the approach, and it's very exciting. I do want to ask about the one thing you said sort of in passing, is that you heard from people that they don't like to go to the emergency department for this. And I think that is true for the populations who are aware of this and aware of PrEP and PEP. However, I think for large segments of the population at risk, the emergency department is still potentially a very important venue to do some of this work. Could you talk about where the emergency department fits into the plan?
So we continue to promote post-exposure prophylaxis in emergency departments frequently. And we'll continue to do so. And part of that promotion is, what is the second step after the emergency department? So very often, people are started on a small supply of medicines and then it falls apart. And so the outreach to the ERs is keep doing what you're doing, because for the most part you're doing it well. I don't have a slide to show you this, but we've actually done syndromic surveillance of PEP use. And the ERs have shown an astronomical increase in PEP use because people are aware of it and they land there. But the problem is the second step of where do I refer them if they're uninsured or if they're underinsured? Will my HIV clinic see them? Do I have a contact in the HIV clinic? So our answer is PEP Centers of Excellence will see them, which is why we're launching them in 5 boroughs. So we have more reason to speak to ER doctors now and ER providers because they love to know what their subsequent step is. And now we have a very clear one: STD clinic or PEP Center of Excellence for completing the course.
Absolutely. I would encourage you to think about the ED, though, also in terms of screening and for PrEP as well. So I'd be happy to talk more about that.
Oh, I love that. We would love to have a good plan for PrEP initiation. You know, nationally, the Gilead data, the company's data for the drug actually shows that the ER in the South is a very common start location for PrEP and also a place where people come as a safety net to continue their PrEP.
I have a question about the, well, first of all, let me also thank you for your presentation and your work in this field. I'm just interested in the communication about all this sort of new standards, expertise, and health education and outreach between or among the new centers of excellence, the STD clinics, and the sort of community-based health centers doing sort of ongoing primary care. I know many of them have some expertise in HIV treatment and certainly testing and education. So how do you see the whole system working for the hundreds of thousands, millions of people that sort of need this information?
So first with the HIV, the people living with HIV space of this equation, one of the things that we've done in the last 2 years is we've been publicly releasing people's viral load suppression rates so we can identify facilities that are the most effective in treating people in a timely fashion as well as getting and keeping their viral load suppressed. So from the perspective of clinics that do HIV, we're actually working with the clinics that are lower performers to improve their performance through a very good interaction with the state. The Bureau of HIV has a group that does provider communications and outreach, and they're actually going in with the states to underperformers for their organizational assessments, and we'll be launching a survey to sort of check the friendliness of the clinic for the populations. From the perspective of delivery, in the STD clinic, the organizations that will be receiving patients who are jump-started are going to be the ones with the highest level of viral load suppression. So we're only referring to places that are 85% or better viral load suppression to make sure that we continue to provide high levels of service for our HIV, our newly diagnosed people with HIV. In the PrEP space, in the prevention space, one of the things that New York City is known for right now nationally is that we have the most mature detailing program for pre and post exposure prophylaxis, and we're actually specifically going to primary care settings, FQHCs and other frontline staff, including the ERs, to actually teach them about pre and post exposure prophylaxis. And what we've seen in our pre and post data from these visits is a statistically significant increase in providing correct information about the interventions to patients and also prescribing PrEP. So the strategy is to continue outreach to those places and to also vet the venues that prescribe PrEP. The state has a very long list of PrEP prescribers. The way that you get on the list is that you send your information to the state. To get on our list, you have to fill a questionnaire, and then we secret shop you to make sure that you're actually doing the right work and that you're doing it in a friendly way. So we help the state, we give them that information. We're actually going to help Emory, that's launched with the CDC a PrEP locator, because our level of requirement for our PrEP sites is higher than the standard that Emory has set. So I think that answered your question.
Yes, it does. The other thing I was interested in is the slide that you put up about, I think it was Stay Sure, what was it?
Our new campaign,
Yeah.
which is somewhere, there we go.
Stay Sure, emergency PEP. Do people know what that means?
They will if they read our small print. So what we found from PrEP when we launched that campaign Stay Sure is that we actually increase PrEP knowledge because people use their smartphones and Google. And so they can also go to our website with a lot more information, but we've been very clear that part of our charge in doing our promotion to New York City residents is not to just tell them what they know, but tell them what they need to know. And so we'll put things out there like the word undetectable. So we were the first jurisdiction to use undetectable on the subway and then describe what undetectable means. Same for PEP. So we expect that this will increase knowledge. We actually, in focus groups, tried to see what happened if we put one poster that said PrEP or PEP. No one understood. It was a disaster. And so they wanted us to sort of differentiate PEP somehow, so we gave it the moniker emergency to differentiate from daily PrEP. And so that's sort of what the sort of focus group strategy has been, and I think it's pretty effective. And I think also a lot of other jurisdictions are watching to see what happens because everyone's given up on PEP. They're focused on PrEP. And I actually think that it's not a good message because PEP actually supports condom use. It's your option if you're a condom user and something fails. So by only supporting PrEP, the message you're giving out as a jurisdiction is that you don't believe in the condom. It is a subconscious message. So by us doing both PrEP and PEP, we are encouraging both condom use with PrEP, but in the case that you're not, if you are a consistent condom user, we have a way to prevent HIV there as well. And so what we predict will happen is what happened with PrEP. And we do formal evaluations of these kind of Madison Avenue style, and we saw that people actually learned what PrEP meant by seeing it on the subway for the first time, with people that didn't look like it was the end of the world, like the sort of joy and the happiness and the sort of, affection and sometimes strength that we demonstrate are something that people really like in our campaign.
Very nice, thank you.
Thank you.
So, very exciting stuff. Are there any other comments or questions? Thank you, Dr. Daskalakis. This has been a real jewel in the crown.
Can I make one just quick comment?
Sure.
I often sit and represent the Bureau of HIV whenever we present about ending the epidemic, and what's really important to say is that it is a disease control, it is an agency effort, and really the hero in this is not the Bureau of HIV, the hero is the Bureau of STD, because they have completely renovated their entire mission and have taken what their strategy was and given it really true implementation intervention. So they're the ones who need the applause.
Oh, thank you. So that was very well put and reflects the kind of collaborative spirit that's existed both within the disease control and actually a real alignment that we've seen with the advocacy community, a community with which we in the past as an agency had debate and discussion. Before we break, I would like to acknowledge that Dr. Varma, who has led disease control for 5.5 years, beginning in 2011, will be leaving the department in February of next year. But this is his last board meeting, and he's often appeared before us. When I first met Dr. Varma, it was actually HIV/AIDS that we began talking about. So I hope he feels the kind of reward for seeing so many of the ideas that he initially raised, ranging from improved services to all of the fingerprinting and the high science that we as an agency have been able to embark on, coming to fruition under the epidemic. But of course, Dr. Varma has done so many things with the agency, and I would like to just take a moment of the board's time to remind you that he's been our incident commander, first with Ebola, later with Legionnaires, just this past summer as we confronted Zika in the Caribbean and the Americas. He also has started, I believe, confronting an outbreak of meningitis among men who had sex with men. He's led us through hepatitis A scares, and he, in all of this, has been quick to use new technology, quick in every way. So I think always the sort of the best way to commend a real leader is to say some of the things that his team says about him. So I would like to read some comments that came from the team. First is Jay's ease in handling high-stress activations. As I mentioned, he led the Ebola activation for 18 months, and there was a time when we were activated for multiple infectious diseases, namely Ebola and Legionnaire's disease. He is an exceptionally fine writer, and as known as the Iron Chef editor, he is able to pare down and boil down ideas and explain them with great clarity, and he can do this with blazing speed. He could do it, his team notes, even blindfolded and standing on a chair if necessary. And of course, he has supported innovation and out-of-the-box thinking among his team, perceptive, passionate, witty, sharp, superb, extemporaneous public speaker, and an outstanding mentor. So we are very pleased. I am personally benefited. We'll have more time to acknowledge Jay's contribution to the agency, but I wanted to tell the board how important he's been to our work and what a pleasure it's been. He leaves Dr. Daskalakis in the position of acting while we conduct a search for his replacement. Thank you, Dr. Varma, for your service. And with that, if there are no further questions, I'd like to call the meeting to a close. Thanks to the board, as ever. Best wishes for the holiday season.